Hi everyone, Emily and I are going to be talking to you today about Noonan syndrome. So a brief definition of Noonan syndrome is that it is a common genetic disorder associated with atypical development and congenital abnormalities. Some of the most common symptoms of Noonan syndrome is facial dysmorphology, short stature, and cardiac abnormalities. And in our next slide, we have a picture here to give you a visual of what an individual with Noonan syndrome typically looks like. So you can see the webbed neck here, as well as the forehead and the slanted eyes. When we look at the etiology for Noonan syndrome, like I stated before, it's based off of genetics. So it is based on an autosomal dominant genetic mutation. There are 12 possible mutations that an individual with Noonan syndrome can have. However, the most common type is PTPN11. This is identified in about 50% of individuals that have been diagnosed with Noonan syndrome. When we look at the prevalence and prognosis, Noonan syndrome occurs in about 1 in 1,000 to 2,500 live births. However, this number, it can change mainly because some individuals with a milder case of Noonan syndrome often aren't actually diagnosed with the condition, so those are often left unaccounted for. When we look at the prognosis, some mutations typically do cause a severe or long-term symptoms like the heart defects that I've talked about, and they do vary depending on the clinical presentation and complications. However, the cardiac prevalence in most individuals is typically high, with about 50 to 80% of Noonan syndrome cases having some sort of a congenital heart disease. When we look at the medical management for Noonan syndrome, like I stated, most individuals do have some type of a cardiac deficiency. Some of these mild cases can be left untreated. However, if an individual has a moderate to severe cardiac condition, these do require surgical interventions. The most common type is a balloon vulvoplasty, and any cardiac condition in a Noonan syndrome patient is treated like a typical pediatric heart condition. When we look at the hematological factors, most individuals that have been diagnosed with Noonan syndrome do have some sort of a bleeding disorder. And this is characterized by factor deficiency and platelet defects. However, this can be treated using factor 7A. With the endocrine system, like I've stated before, some individuals have a short stature and they have delayed puberty. However, in order to combat this, most individuals are treated using growth hormone therapy. There are other areas of an individual's life and body that do need some sort of medical care. And as long as these individuals are continuously followed up, monitored with specialists, especially their primary care providers, these areas in their medical treatment can be monitored in that way. When we look at the psychosocial implications for individuals with Noonan syndrome, some individuals experience a stigma due to facial differences, which can lead to anxiety and then even depression, which is commonly seen among adults with Noonan syndrome. Their families can experience fear, anxiety, and stress due to the uncertainties of the conditions, and OTs can help with this and the parents implementing coping strategies.
So what is the role of occupational therapy? We kind of split it up based on the common deficits seen in individuals with Noonan syndrome. In regards to motor delays, commonly seen is hypotonia, motor planning deficits, and muscle weakness. And these delays can be approached using dynamic systems theory or the motor control motor learning theory to teach them movement, or using the biomechanical frame of reference, using things like strengthening or positioning to help combat those delays or help rehabilitate those delays. In regards to cognitive delays, commonly seen is executive functioning problems, attention deficits, and memory delays. And this can be commonly approached using the cognitive behavioral or behavioral frame of reference. So utilizing things like reinforcements or teaching clients their own strategies for self-monitoring. Some language skills that are commonly delayed is communication and emotional expression. And this would be treated in collaboration with a speech therapist. The speech therapist can cover the actual speech problems, and then the OTs can come in and play a role in social participation. And then super important, area that OTs can help with is cardiac rehabilitation. It's been found that pediatric heart conditions can negatively impact body functions and development. So this requires a holistic approach from OTs to address how those cardiac issues are impacting their functioning and their development. Occupational therapy interventions, some things that are important to keep in mind because we are working with pediatrics, they should be play-based. And that means you can use occupations as the way to develop underlying skills, or you can use it as the end goal is them engaging in age-appropriate play. Collaboration is super important. Family-centeredness is so important, especially in early intervention. And then teacher and special educators, when kids become school age, whether their therapy is in the clinic or is in the school, we want to see those transfer of skills and their functioning in the classroom. And then, of course, being client-centered. We want to use meaningful and motivating activities for functional outcomes. We want the kids to be actively engaged so we can get that transfer of skill and that learning to happen. So this is our case study. This is Lily. She's 33 months old and she was diagnosed with Noonan syndrome at birth. She's currently receiving early intervention occupational therapy and also speech therapy. Her support system includes her mother, her 14-year-old brother, her nanny, and she has a dog. In regards to her socioeconomic status, she receives child support from her father, and her mother is a very successful attorney, putting them into the mid to high range for SES. And then they live in a 2-story house in Montecito with a large backyard and pool, which is super great for her exploration and play. She loves animals and swimming and Paw Patrol. And she, in regards to her background, she was born with a mild ventricular septal defect, but it was so mild that no surgical intervention was necessary, just monitoring. Her gross motor, she has hypotonia in her lower extremities, which leads to a clumsy gait and W sitting. She presents with a palmar grasp and frequently drops items due to decreased fine motor strength. She is easily distracted, has frequent outbursts, and shows lots of frustration with difficult tasks. And she is receiving speech because she currently is only presenting with single word utterances. And in regards to play, she's only doing solitary play, which is not age appropriate for an almost 3-year-old. So in regards to her present level of performance, these are some functional problem statements, and all the things I've mentioned are impacting preschool activities, peer play, functional play, and self-feeding with a fork. So the 3 occupations that we'll be covering in our interventions is sensory motor play, self-feeding with a fork or utensils, and social play. And here you can see the client factors and performance skills impacted. So our first activity is a sensory motor play activity in the backyard. It's an obstacle course. And our rationale for this, we want to start off with some movement for that dopamine release to promote attention and focus for her tabletop activities because she does present with low attention. We want to incorporate play-based and motivating activities to help develop those motor skills to improve, increase opportunities for exploration. And then strengthening. The things we do in the obstacle course are actually going to help improve that low tone that we're seeing, her decreased fine motor strength, and help her with her dynamic sitting balance. Our second activity is a self-feeding activity with utensils. We're incorporating motor control and motor learning concepts in this, which includes stuff like whole task training, feedback on performance and results, demonstration of the task. And through all of these things, it's said that it can help develop improved neural pathways and help the child learn those proper movements. And then we also use the idea of proximal stability for distal mobility. We incorporate positioning into this activity and educating the mom on positioning for tabletop activities. And this can help allow for optimal movements needed for functional tasks. And then our last activity is a social play activity. Because she is currently only doing solitary play, we want to start moving her towards more age-appropriate play, which for her would be parallel play. So our Activity actually targets imitative play to introduce new skills like mimicking that's needed for parallel play, which would be more age appropriate, which is the long-term goal we will eventually get to, but right now we're just addressing the short-term goal. And then co-regulation. Through modeling, teaching, and feedback from the mother, it can help to promote self-regulation and hopefully teach Lily skills that she can be able to use the self-regulation in other play activities. And these are our references.